We're going to begin at the lower body, work our way up, do some hip, knee, shoulder joint, and kind of go from there. I'm planning on working on both sides, so if you do have a buddy, you'll have that opportunity to practice with them on the other side. One of the most important things that we feel is our presence. We really believe that techniques don't heal so much as your presence heals. So, finding a moment to ground to center, to plug into the present moment, let go of whatever happened yesterday or what's going on tomorrow, let go of the weeks and months ahead and behind now, and set up that intention. If you had an intention for your class today, what's your version of success? Maybe realign, recalibrate to that intention. My intention is to have a really good time, have a lot of fun with you while I clearly share the best and brightest of what's been effective in my practice. All right, so first thing we're going to do is give a little attention to the hip and the leg. So I'm going to begin. I'll just bring Nicole's hand out of the way so I can come right next to her body. And I'll probably move the camera a few times. And I love requests. So if anybody has particular requests as we're going through this, let me know so that I can be sure to give you that kind of attention. So the thing we're going to be doing here first is working with the lower body, working with the hip. And this, of course, is going to help support the knee and the lower back. So find ASIS and just move an inch or less below. So we have ASIS, interior, superior iliac spine. If you move about a half an inch lower, then we are getting to the AIIS. And I'm going to simply place a forearm here, and I'm going to begin to drop my body weight. So first I'm just creating a nice compression here. I'm not on the bone, but I'm on the tendon, specifically the upper rectus femoris of the quadricep. So check in with your pressure. I want it to be, especially if, and this could be post-surgical, hip replacement, knee replacement, or someone just experiencing discomfort or projects in those areas.
OA.
Yeah, OA, arthritis in the hip, just hip pain, tension, stiffness, bursitis.
Yeah, and appropriate for anybody in those steps leading up to surgery.
Yes, yeah. Great. So I like to take what I call a kickstand position. A lot of people are familiar with the archer's position, outside leg forward, inside leg back. I'm going to actually reverse that, bring my inside leg forward. I'm resting my seat on the table, and my leg is either out sideways. Let me get a little better view of the lower body here. My leg is out sideways here. Yeah, or it could even be back behind me a little here as well. And so hanging out a good 30 to 60 seconds and getting friendly with that area, getting feedback is that, and we want to find the what we're calling Goldilocks intensity, not so much that it takes their breath away, but not so little that you're just going through the motions. We really want to get in that deeper fascia, help reorganize either disorganized fascia or dehydrated fascia, get some more blood flow into these areas. And this is a very easy ergonomic position. I'm a little slanted, but in general, my head's over my heart's over my hips. I'm not rounding forward or cockeyed, twisted sideways. And then just in this one little, it's almost like a 2 square inches, right? Below the ASIS at that top of that rectus femoris attachment. And we're gonna do a nice forearm roll. So I sink in with my pressure on the meaty muscular part of my forearm, my wrist flexors and extensors, and then I'm just moving from pronation to supination, and then I release. I sink in, and I'm moving longitudinal because I'm moving in alignment with the fibers. And you could even coordinate and synchronize this to the breath, so they could inhale, and then as you exhale, you could drop the pressure in and then do that forearm roll. And you're not sliding your forearms, right? You're not moving like this.
Be all done over the sheet.
And this could be done over the sheet. You don't have to do any draping for this. But again, you're staying in about that square 2-inch area on the top of the quads.
It's usually pretty thick.
And yeah, it's usually generally a little thick. So find that Goldilocks edge right before they would wince. If they start wincing, that's a sign that you've gone a little too much, too far. And so a good minute or half minute, I would put everything into about 30 to 90 seconds for how much time to work with this. So longitudinal work with, or what we can do, I'm not going to roll my form, I'm just going to simply bring it out lateral. So I'm going to sink in depth, and then I'm going to begin to drag the tissue lateral out to the side. I sink in, I'm still below the ASIS. I can feel those tendons of rectus femoris. I'm also getting really close to the upper portion of vastus lateralis, medialis, intermedialis, and
Like shooting pain.
and Nicole, just with me pausing and sensing the top of the quadriceps, even before I moved, she could feel, could you say that again?
Like referral pain down the knee.
Shooting pain right down, is it right down the center of your
Yeah,
leg?
right on top of my
Yeah.
patella.
Right down to the patella. Great. So again, about 30 to 90 seconds here. And was there a question?
Is this technique for like the knee surgery or hip surgery?
Both. Yeah, it's appropriate for both hip and knee. Does that answer that?
And anybody else who has any.
Yes.
And it doesn't have to be specific to surgery. This could just be tendonitis bursitis for the proximal areas we're working.
Or arthritis in the joint.
Or arthritis in the joint. So we're talking about surgical interventions, but this is also perfectly appropriate and indicated for people, any kind of hip or knee projects. Cool. So we just start static pressure, then a little longitudinal, and then a little cross fiber. Great. So getting the upper attachment. So a lot of RSIs, of course, happen in and around the joints, ligaments, and tendons. If you release the tendons first, especially with cross fiber friction, you'll release the belly of the muscle automatically. So remembering a lot of proprioceptors, spindle cells, Golgi tendon apparatus are up near the joints, the tendons, ligaments. So important that we spend a lot of time at the attachment sites. Next, we're going to take the, is there any other questions before we're going to move the leg off the table? Okay, great. So whenever I'm moving my client's limbs, I let them know, I'm going to move your leg off the table. And you can do this right over the draping. Again, we'll show it later on if you want to see how this would look with the draping. That's fine. I'm going to bring it out. I let them know I'm bringing your leg out and off the table. Great. And if you need to adjust the bolster because it doesn't give you enough room, do so. But I feel like that gives me the room that I need. And now I'm going to do just a teeny, I can still work. There's a lot of elastin here. I want to work the inferior attachments of those quadriceps. So I can take a nice forearm roll again, and maybe now, let's bring this a little closer to what we're up to. And I'm going to get one more light to get us the angle that supports this. Excellent. Okay, so now I'm going to work the inferior attachments. Oh, that's much better. I can see much better what's going on over here. And I could use, I'm going to use my forearm again. And so again, all four quadriceps connect to patella through the patellar ligament, connect to tibial tuberosity. And I'm going to, again, just on the top of just superior to the patella, I'm going to add a little pressure. And I hold, I wait. I want the body to get used to my sensation, used to my pressure. You could do this from a rolly stool. That's what I would generally be doing in my own private practice. I don't have a roller in here, but you could be sitting on the roller. Or you could take a knee, or if you want to do a really deep knee bend, you could do something like this with an archer or a kickstand. And after the compression, then we're going to add that forearm roll. So we have three main lines, four quadriceps, but three main lines. We got vastus lateralis on the outside, vastus medialis on the inside, rectus femoris and vastus intermedialis in the middle. So I'm going to change my angle so I can get the medial attachment, the anterior. Ooh, you okay with the pressure
Mhm.
attachment and also the lateral attachment? You can see when I'm using my forearm, my palm is facing my belly, my shoulder and elbow are lined up. And that's good for your body mechanics. You don't want to have your elbow out here with your hand away from you, or you could blow out your shoulder. And you don't want your elbow in front of your shoulder when you're applying pressure, or you'll be putting force into a misaligned joint. We want that shoulder capsule to be neutral as we're creating these types of uh, techniques, these touch therapy techniques. So we help release the inferior attachment. This will be partly associated with hip, but more specific to the knee. And make sure I don't miss anything. And now I'm going to add a little lotion. So go ahead,
Do the
Nicole.
Compressions all the way?
Okay. You want me to do that first? Let's do that.
So before you don't slide. I don't know, though, maybe
I
you
can-
do. I don't know.
This is no problem. We can change things. Nicole suggested I do a compression all the way up. And maybe it was just a request because she loves to have her quads work. And we're going to work all the way up the middle line. So that's the vastus intermedialis. And when I see her, I want to be sure we can see some of her facial expressions. So the
Goodness.
folks back home can see her. Oh, and so when she does make those big facial, or that she takes a really deep breath, I don't want to antagonize her. I don't want to like fight her with it, but I do want to slow down and maybe give it a little more attention by hanging out longer, or maybe a few more repetitions. So I'm not using the sharp of my elbow. I'm about 2 inches off, and I'm on the ulna blade.
Are you sure?
It feels like an elbow. You don't have to use the elbow.
I'm just kidding.
We could do the same thing
Okay, you are.
with the lateral. So get this rolling pin. This is a Thai massage technique, rolling pin or forearm roll. And you can take it right over the sheet or skin to skin, and before we add the lotion. And so, she had a wince there. I don't want to go back in and attack it. I want to go back and support it. Good. And if she tightens, that could be in the form of a wincing face or a held breath. I want to back off or encourage her to take long, slow, deep breaths. Is that manageable there?
Yeah.
So intense, edgy, achy, perfect. Holding your breath, tightening, not cool. So find where it's manageable intensity. And then we can take the line up the medial compartment. So this could give you more idea about, do I want to focus more medial, lateral, or anterior? Where is the band of fascia? So I just noticed here between the adductors, and the quads, there's a little gluing up. That fascial net is adhering, it's twisting in on itself, it's getting a little dry, hard, brittle, not as much oxygen flow. So I press in, and when I release, it changes the volume of the fluid in the area. I push the fluid out with my pressure, and then that creates a vacuum as I release, and hopefully, ideally, the blood, the nutrients will flow back in there. So I would definitely like to focus a little more up there. Good?
Yep, great.
Now I'm going to add just a little bit of a lotion. And we like to use a dual purpose, something that is going to give you some good grip. And we just add a teeny tiny bit. You can always add more. So what I'm going to do, I can use a single soft fist. So soft fist, the back of the palm, wrist, forearm are all on the same plane. Yeah, and I'm just going to take my soft fist all the way from attachment to attachment. Good. And notice I'm not white knuckling. I can check the medial compartment. My belly is always behind the technique. And my fingers are soft. I don't want to curl my fingers under. Definitely don't want my thumb under. You want everything nice, floppy. The hand is very soft. You're not gripping it. And then I want to get the outside. And for me, it helps for me to change my angle. So I came all the way out here for the lateral side so that my belly is always facing the work. Good. Nice deep breaths. And notice I'm taking my time for this fascial reorganization. The deeper I go, the slower I go. So I'm going pretty deep, and I slipped over the clothes. Fortunately, there wasn't pressure with the slipping. Now that's really, really nice kind of warming up, but what might be really beneficial is if I start to do a little range of motion. I'm going to be beginning to create a little range of motion, either with the forearm or soft fist. And I'm taking this position for the camera. So I can simply, I'm holding underneath the crust, the calf, and I'm simply taking a little range of motion. I could go up the whole length of the leg, or if you don't have the length in your own body, you might only want to focus on the lower portion. So for the sake of the camera, and for people who aren't as tall, we can just find the outside and do about 3 to 5 repetitions over that inferior attachment site of the quadriceps. Do the same right over the anterior portion, right through the middle. Doing okay?
Yeah, that's great.
Good. And then for the medial, I like to change my position so that it's super easy on me. And you could either glide, you could hold stationary, you could do that rolling pin. But I'm only moving, again, about, maybe now about 3 inches. So just the lower 5th or 6th of the quadricep. Now I was straightening and relaxing, but maybe now I want to add a little more flexion. All right, so now, and for me, the tool that makes the most sense for me is my forearm down here. So now I'm going to begin to flex the knee as I add my forearm. I'm going to flex it back. Does that feel comfortable?
Very.
So, of course, if they had a surgery or any kind of knee vulnerability, I'm going to be really mindful. And again, I'm primarily just going to be working this lower quarter, but again, I want to work comprehensively, 360 degrees, not just the front of the quad, but the medial and the lateral aspect of the quadriceps. Ooh, get into IT, right? Huge stabilizer for the hip and the knee. Iliotibial band serves as an attachment site for the glutes, so it has a very powerful impact, not just on hip and knee stability, but also on how you feel in your back. So here I'm really emphasizing, I'm not going for a deep knee bend. I'm just going as far as the table lets me, or as far as their range of motion facilitates. Doing okay, Nicole?
Mm-hmm.
All right. She seems pretty relaxed, even though we're definitely giving her the business. That's what we want to be doing.
Well, I feel myself progressively relaxing.
Oh, good.
Like it started out a lot more.
Yeah, at first kind of really, really intense because there was a lot of new sensation in those big compartments.
Did you slide glide all the way up? Did you slide glide? I didn't feel it.
We didn't go all the way up, but we sure can. So what we're going to do now is a nice.
Do I call for motion again?
You've got great ideas. I'm going to follow the list.
Oh, sorry.
Yes, I've got techniques that we have written down that we shared with them. I'm going to go through those. And if you have extras,
okay,
you let me know.
all right.
So she had an extra. Can you go all the way? Yeah. And let me, not you. Oh, not you. She want to go all the way up the leg. And here you can get fancy. And so you can gently facilitate knee flexion if you've got the balance. So I'm balancing on my left foot.
You're
on
so fancy.
Floor, and then my right foot is helping do that little knee flexion. So there's lots of options if you want to go over the length. You could go this way, but again, you want your belly button. You want your belly button. Here's double soft fist. Your belly button is always facing your stroke. If your belly button is facing another way, you will have low back, shoulder, or neck tension, or all the above. Now, this is what Nicole has been wanting.
What's that?
The call for motion. So far, we did static. Then we started to move. We got the leg off the table. I added range of motion. Now she is going to do the range of motion, which moves it from like maybe a 4 or 5 on intensity up to that 7, 8 kind of level that really creates a lot of longitudinal difference. So what I'd like you to do, Nicole, is you're going to keep your leg up. And then as I perform the stroke, you're gonna slowly lower it down, okay? And you'll take about 5 seconds. So hold it up and I'm gonna let it go. Go slow, 5, 4, 3, 2, 1. Good. I'm gonna lift up. You can lift, therapist or client. I'm letting go, but then you control the descent. And here I'm just moving a little. I'm just moving maybe that lower quarter. Yeah. One more time. So do this the slowest. Keep it straight for me. I'm even going to add another plane. Flex your toes back. Keep your legs straight. Keep it up. Keep it up. Good. And now slowly lower. Flex your toes. Slowly lower. And that just makes it more challenging, and let that go. Good. She's just engaging this front line that connects all the way from the top of the foot, tibialis anterior, all the way up to her head. So you can have her do the letting gravity take it, which is a little easier, or we're going to do the reverse.
Mm-hmm.
So especially when you're trying to get things to fire and activate again, instead of doing the relaxation phase, we're going to do the engagement. So before, the quadricep was relaxing as she let it down. Now we're going to do the quadriceps. She's going to slow motion kick the soccer ball. Yeah. And inhale. And again, exhale. Let's go straight for 5, 4. I'll move my body out of the way so you can see 3, 2, 1. Good. Let that down. I'm going to try a different tool so you all can see a little better. 1 or 2 soft fists. Inhale and exhale. I like to do the technique on their out breath. Make sure you don't get kicked. Let that go. What you may want to do is focus around with the knuckles. So we went soft fists, back of the hand, wrist, forearm in line. We did forearm. Knuckles, now the back of the fingers, palm, wrist, forearm, all in the same plane. I'm using the flats of the knuckles, not the sharp. And I'm going to just be moving this way, like I'm spreading and parting the top of that tendon. So let's go ahead. Inhale here. Exhale, slow motion kick up for 5. Straighten that leg. 4, 3. Can you make it straighter? 2. Okay. So maybe try less pressure and less time. We're going to do it for a count of 3. Ready? Inhale here. Exhale. 3, 2, 1. Okay. Knuckles are too much. Let's use our fingers. Inhale here. Exhale. 3, 2, 1. Release. Guys, girls, ladies, I'm using that much pressure, just so you know. And she's having a significant impact. And that's what we want, right? We want to have maximum positive impact with minimal effort. Great. You feel good with that section?
Yeah, feels great.
Great. Before I go on to new techniques, are there any questions about that first kind of hip to knee work that we were focusing on? Okay. Let's continue. Right. Oh, come on. Please go ahead.
What if they can't move their leg out like that?
Yeah, if they don't have the mobility to do that. Is that what you're asking?
Yeah.
Like they don't have the range of motion, or they have some caveat where they can't take their leg off?
Yeah.
Yeah, you won't do it. You leave it out.
Well, are there any other techniques to try to get that length in there?
Oh yeah. When you do so a variation on this would be to do some prone work. So we can also have, if they're in face down, they can begin to bend their knee.
Mm-hmm.
Should we show that real quick?
Oh, sure.
Okay, so let me have you roll over. I can show a modification.
I don't know what you're talking about, but
That's okay.
okay. Oops, sorry.
All right. This isn't in your handout, but so they can't take their leg off, no problem. What we can do is we can have them do knee flexion and extension in prone position. And instead of being on top, I mean, you could certainly work the back of the knee, and that would be fantastic. You could certainly work ischial tuberosity in the hamstring or any of these other compartments. But if we are looking primarily toward getting the knee helped out, then I would undrape the leg. I would start with the knee here. Let me get a hand towel so I can show proper sanitation. So I can have a hand towel supporting my shoulder, and I could start by simply scooping under. So if I had the pull through drape, I would hook under quadricep. You never go under the drape, but you can go under the body. And I'm just going to scoop and sculpt. And I could do something like sliding my hands under the quadriceps as I did this kind of motion. So I could say primarily at that lower quarter of the knee, and we could do it like this way on the outside. We could switch our hands, and I'm scooping, you can't see, but my fingers on the inside hook under the lower tendon, and we can do, and all I'm doing is I'm just scooping. It kind of looks like I'm doing this above the knee as I am encouraging the range of motion. So that could be the range of motion variations. And I want to be comprehensive. I want to work all over the bottom of the quadricep attachments, medial, lateral, anterior. And then I would ask them, so in a moment, Nicole, you're going to slowly lower your leg down like that. Does that make sense?
Okay.
Okay, so hold it up. Good. And then inhale, slowly lower it down. And I can support static pressure on the lower quads. Good. Before I was helping them, so you could help or you could make them do it. Hold, inhale, exhale, and slowly lower it. I could hold static, or I could start to glide and slide. I could do some longitudinal friction, or maybe I want to hook under a couple of the tendons, hold it up, and slowly lower it, and I'm going to scoop cross fiber friction. Okay, so those are some options that you could have them do if their leg doesn't have the mobility to come off of the table. Does that answer your question, Shanice?
Yes.
Okay, good. Great. Let me have you roll over again, Nicole.
Okay.
Okay, so let's focus directly. If they had that knee replacement, remember that big, nasty fibrosis scar from all the staples and the keloids and the raised tissue? We're going to focus really specifically right at and on the knee. So let me get everybody a nice camera level for right on top of the knee. That looks good. All right. All right. So a few different options. We can certainly do some myofascial traction here. So I'm just hooking in with my fingers above. I don't have any lotion. I don't need any lotion. In fact, I don't want too much lotion because I don't want to slide over the skin. I want to slide the skin over the muscle. So here I'm going to hook in just superior to the patella. I can feel the kneecap under my finger pads, but my fingertips curl around softly, and then I'm just going to angle up toward the head. And it's as though I'm trying to stretch the skin over the muscle. I just hold here. I'm using just a couple pounds of pressure, not a whole lot, not really deep. But I hold for about 30 to 90 seconds. It takes about 30 seconds, 20 to 30 seconds to overcome the first myotatic stretch reflex. So after about the 20-second mark, that's when about here the fascia begins to yield. And again, I go into that medial, anterior, and lateral aspect of the quadricep. So I can do a very nice, this is like a longitudinal myofascial. So we're going in alignment with the tissue, and this would be very specific to that long scar. So you could be you could start right on the kneecap, and then you could be a little more, you could have a faster tempo is what I was going to say. So I can hook in and imagine you're stretching the skin over, or the scar over the underlying muscle and bone. So we can do that longitudinally above the patella. I'm going to do the same thing longitudinally below the patella. Yeah, I like to pull the fascia away from the knee rather than pushing it into the knee, but find what works best for you. Do you have a preference, Nicole?
No,
So find what really works good for you and your body mechanics.
that's good.
You can go over the patella and get the tendon, and that can create a lot of sensory rich information. So I'm taking the skin tissue from above the patella, and then I just bring it about an inch or two here. Yeah, and Nicole's saying wowzer. Let me make sure we can see that nice and keenly. So hook in and think of stretching the fascia up and over the bone. And when you get over that ledge, give it a little extra. Oh, they just open it up and release it like this. You could start below, but so notice I started the path of least resistance. We already had the lower quads opened up a little, so I started with that. And now it's a lot softer. And then I just kept going a little further and adding more areas to that longitudinal friction. After you've done a bit of longitudinal friction, we can also do, of course, cross fiber friction. And maybe you're doing little C shapes.
There you go.
So you could do like one C, or you could do S shapes. Good. Go all kinds of different directions.
And you're directly on the scar tissue.
And yeah, you're going to be right on the scar. So you want to move everything all kinds of different directions. And you can also go up and down if you can.
After the scar is healed.
Yes. What do you mean? After the stitches are out?
Yeah.
Like after the so you wouldn't do this like over staples, everybody, right? We're talking about that 6 weeks after, and it's raised. All right, just so you know, you wouldn't.
Even if it's not raised, you can still do this.
And it's highly recommended that you do it even if it's not raised. And that's going to help with the underlying tissue that isn't necessarily scar tissue like a keloid, but is oftentimes disorganized because it's been cut through in the middle and in that little half moon way as well. So we get cross fiber. Cerix is another way we can move in. So oldie but a goodie. You interlace fingers, and we can do, this is sometimes a little more amenable. And nice way just to give the body and yourself a variety of techniques, of sensations. Keep it interesting for yourself.
Makes my knee itchy.
Ah, good. Her knee is itchy. And if you've ever, with wound healing, one of the last stages of a wound healing, when it scabs up and stuff, it gets itchy. And that's a sign of lots of new messengers, blood getting here. You may be even able to see there's a little more pinkish in this area, even though we haven't done like a bunch of deep work. So we can do, we could even do open palm along the length of the scar and just connect it in with the other work that we've been working on.
We're going to get the medial scar?
Yeah, let's get the medial. So let me show on this side. So we've got the longitudinal scar right over that knee, above and below the kneecap.
Yeah, it's kind of like the center line.
And then there's this little half moon shape here. That's usually an incision that isn't necessarily, you can't see it above the skin, but it usually happens in the procedure. And so here, we're going to just follow this horseshoe-like shape, this little half moon-like shape. And again, we can, some of you know the pes anserinus. That's where the adductor hamstring sartorius meets on the medial shin. So that could be a place where you do a little cross fiber. And this tissue is a little more sensitive and tender on the medial compartment. So I am adding some lotion. It'll be less friction, less heat. And generally that's a little more friendly. The myofascial I was doing earlier on and above the kneecap, that was without lotion, so we could get a little more heat. So again, we can do cross fiber, we can do longitudinal, it's all recommended. a soft fist, just because they have replacement knee parts here, you can absolutely use your advanced tools. It's indicated. The new hardware is helping create stability. You could try the Cerix. So just be sure, not only over the scar, but make sure you get that medial compartment just above and below the femoral condyles. Should we show that on the other side real quick, or should we show other stuff?
I don't know what's show that.
Should we do all of that leg stuff on this side?
Oh, sure.
All right, I'm going to
I don't
do
have that
all
much
of that
time.
pretty quickly. So second side, about a quarter of the time. Sound good?
Sounds good.
See how we are on time. Okay, we have about 20. I think I'll be able to do this in about 5. All right, so other knee, stop me if you have questions, but I'll just kind of go through the different sequences
Yeah, a
for
little more fast.
the hips and the knees. So find ASIS, go just below. I take that stance and I allow her to feel a few deep breaths. My pressure is slowly, gradually sinking in, my elbow over my shoulder. And after about 20 or 30 seconds, or after I see a calm expression on her face, maybe now I'll try that rolling pin. So a little longitudinal friction right along the top of rectus femoris, and I sink in and scoop up. And again, work a little more medial on that attachment, work right over the attachment, and then of course work a little lateral to the attachment. I still feel the attachment. And then very slowly cross fiber, I sink in, and then I'm going to gently slide out lateral. I sink in and glide out sideways. Sink in, breathe in, and sink out sideways. Yes, and a skill I recommend all of us develop is listening for when our clients stop breathing. That's a sign to encourage more breath or slow down and take another approach. We can also work along the lower attachment. So we did just above the kneecap, and we can sink in, take a few deep breaths. Let the tendons, let the soft tissue, let the joint itself begin to get a little more comfortable. And then I'm going to begin a little forearm roll right over the anterior center in line with the kneecap. I'm going to move my pressure a little so I'm more on the medial aspect of those quadriceps, vastus medialis. And then I'm going to tilt my angle so I'm a little more lateral and ooh, yeah. Even though they often experience more pain on the inside, there's often a lot more tension all along vastus lateralis and sometimes IT band. We're not going to focus much on IT band for this first portion, but super important juncture to release with hip and knee projects. Great. And then I can add that range of motion, and it's not going to be super clear from the table, from the position. Let me do a new camera angle so y'all can see. Don't watch the camera for a moment or you might get a little dizzy. All right. All right, so here we can again begin to simply create static pressure. The tissue's already a little elongated. I can do the longitudinal, I can do the cross fiber. I can also add a little range of motion. So you can't see with this hand, I'm bending the leg. Here we go. So I'm bending her knee, get my hand out of the way. I bend her knee as I'm adding this pressure on the bottom quad. Bend and release. 1,000, 2, 1,000. 1,000, 2, 1,000. And I release the pressure and the stretch at the same time. Give her a moment to catch up. Doing all right? Mm-hmm. Good. I could do it longer. I could do it along the length of all three of those. And again, I feel a lot closer up to the attachments. That's generally where you want to spend a little more time. And then this time, I'm going to ask Nicole, you are going to hold your leg up. And then I want you to slowly lower 3, 2, 1. And begin again. Inhale, exhale, 3, 2, 1, one more, and I'm gonna use double softness, 3, 2, 1. So for her to drop and let go of the quad is easier than engaging the quad. So let's do that again. Inhale. As you exhale, slow motion, kick your leg straight for 3, 2, 1. Let that go. I could use soft fists, forearms, even knuckles. As you're ready, kick that leg straight, gently, slow motion, straight. Ooh. So as I change the stroke, let that go. It'll make the movement, the call for motion, a little more challenging. One more like that. See how straight you can get that leg. Straighten it out. Go, go, go. Flex your toes towards your nose. Flex towards me. And let that go. Whew. Good. I'll release. I'll support under the leg. And then we did the, let's bring it over here. Then we focus on all that myofascial. So I hold and wait for the skin to release over the muscle or the bone. I'm going a little quicker. So think of holding about 20 to 30 seconds. You could always hold longer. If you've got too much lotion on your tools, you might want to wipe it off so you can get a little more grab if you're sliding. And then, of course, we can go along the entire tissue, patella, hook in, and scoop. So start at that patella ligament, tibial tuberosity, glide the skin up and over patella, follow patella with your finger pads, and like a bottle cap opener, hook under and scoop up with that inferior quadricep. We'll do that one more time. Glide, slide. I'm pulling the skin. I'm going over the skin a little, but I'm really visualizing, imagining the skin going over the tendons, over the muscles. We could do the C or S shape myofascial. I could hold. This is for the scar, or this is for hip or knee pain. It's all applicable. It's all recommended. We could do the Cerix and all different directions. Don't forget, really work out. Yeah, sorry. You can see Nicole perhaps really work out this horseshoe part. So we have the major incision here and more the invisible or discrete incision that often isn't external here. So we want to scoop. We scoop Pezan serenus. I added a little lotion here just to make it more friendly because the medial compartment is generally really tender, not as much tissue, more bone, more nerves. And so we just want to be really comprehensive around that area. All right. Did I miss anything, Nicole? Let me double check my notes, make sure I didn't. I think we've got it. I also want to give some attention to the hip and shoulder before we break for lunch. So this is one of my all-time favorites for helping to release the shoulder and the hip socket. And this is what's called a orthopedic technique. Just like you have disorganized fascia outside of the joint, you can also have disorganized fascia inside the joint. We're going to do the shoulder and the hip. We're going to do the same exact routine for both joints, but I'll show the shoulder first because it's easier.
Okay.
No, we're going to do ulcipine. So first thing I'm going to do is I'm going to support the elbow and the wrist, and I'm going to simply traction, little myofascial release. I'm going to hold here anywhere from 3 to 90 seconds. So I'm using only about 30 to 50% effort. I'm leaning back easily, and I just want to create a nice traction in that shoulder socket. After I hear that big deep breath, that's a good sign that you've reached that first level release. Then bring the elbow out directly perpendicular from the shoulder. And what we're going to do now is before we traction the humerus away from the glenoid cavity, now we're going to press the arm bone into the glenoid cavity. Now you can either do it with the elbow straight, or what I prefer to do is to use my side of my thigh and my top palm, and I'm going to keep the shoulder down,
toward the table, and I'm using the side of my thigh to push the elbow, to push the humerus, to push right into her glenoid cavity. And we're just going to hang out there. The reason I have this hand on the shoulder to try to keep it down and back, if I didn't do that, it would just kind of tuck that shoulder up into the ear, and that would just lose the stretch. So instead, I want to be sure that I keep the shoulder down and keep the elbow bent, and then I press and I create this compression. Sometimes James Walowski refers to this as strain counter strain. So we're straining in that glenoid cavity. And we did the traction earlier, that was the counter strain. So just like fascia can get disorganized outside the joint capsule, here we're helping reorganize fascia inside the synovium. After you do the distal traction and the proximal compression, now we're going to do what's called mortar pestle. I'm going to support either around the humerus or the humerus and forearm, and I'm going to press the arm into the shoulder socket. And then I'm going to rotate. Doesn't matter if you internally or externally rotate first. And then I'm going to traction and do the opposite rotation. So I'm not just rotating the wrist. I really want to get the humerus to rotate. So let's do that again. Press in, arm bone into scap, rotate, traction out, reverse the rotate. So the specific rotation I'm doing here, compression, external rotation, traction, internal rotation. We're going to do both directions, but do that about a half a dozen times. Compression, rotation, traction, opposite rotation, compression, rotation, opposite, rotation, traction. Now I'm going to do the reverse. So now I'm going to compress and inwardly rotate, traction, outwardly rotate. So imagine, some of you know that mortar and pestle, that bowl-like ceramic object that holds the grain or the herbs, and then you get the mortar to press into it, grind up the herbs, press in and grind. Great. So compress, inward rotation, traction, outward rotation, compress, inward rotation, traction, outward rotation. Good?
So this
Yeah.
is good for rotator cuff issues.
This is good for any shoulder issue. Rotator cuff, great. Adhesive capsulitis, so if they have a limitation in their range of motion. The bursitis, tendonitis, generalized tract tension, kyphosis, it's good for all of that stuff.
Before and after surgery with Dr. OK?
Yes, 100%. Yes.
Oh, awesome. Thank you.
I've had people not need surgery after doing this before surgery and then learning new things so they could avoid surgery. So yes, it can sometimes, not always, it's not going to be a miracle all the time. And sometimes it absolutely is with a touch therapy intervention. We'll repeat that on the other arm a little quicker. And then I'd like to do the same thing for the hip. And then we will take a lunch break.
No, we're not doing any problem.
Well, we could talk about that, but we are coming up to the 12:30 time.
Okay.
Yeah. So we'll see about that. Yeah, you know. All right, so let's a little quicker second time. Oh, that's not the angle. I'm going to bring you all a little closer to Nicole. Excuse me. Don't watch the camera for a moment as I get my act together. All right, here we go. So we've got traction. So some people can tolerate traction right on the wrist, but for most people, that's too much. And as you lean back, that could be too much. So instead, maybe one hand, Nicole likes it. So she's like, keep that up.
I'm a massage therapist. I need some
Yeah,
space in my
okay.
wrist.
So if you can, hold on to the thenar, hypothenar underneath the palm and just lean back. And you can see your head moves and just rest it. Now, if that causes any discomfort in the wrist, then you simply bring one hand to the forearm and one hand to the humerus, or one hand to the wrist, one hand to the humerus. But Nicole likes it. You like it like this, yes?
Mhm.
Yeah. You could change the angle. You could supinate the hand. You just get slightly different structures. But right now, we're mostly looking to open up the glenoid humeral cavity. Yeah.
I'm trying to relax. my arm.
Yes, good. So give them cues, let your arm be heavy, feel as though your muscles are releasing their grips from the bones. After about a half minute or minute, then we do the strain. So we did the counter strain, the traction. Then I'm going to do the compression. So I like to have an elbow directly out from the shoulder, press the pec down, stabilize the anterior delt, and then press that arm bone, that humerus, into the clavicle. And hardly using a little pressure on this hand so that the shoulder doesn't roll up or crunch the ear. But most of my pressure is just simply my thigh. And we learned this to use all your upper body. So if you prefer to use your hands and arms to push the arm bone in, go for it. We like to use our lower body, our strongest muscle group, our quads, whenever possible. And then let's do the mortar pestle. This is the last portion.
Let my arm dangle by your side
Yeah.
and then do it
Okay.
because you're gripping it.
Okay. So how I usually do it is I press
There
in
you go.
and rotate.
That feels much better.
So I was trying to move the arm out of the way for the sake of the camera, and I was ending up like squeezing Nicole in an uncomfortable kind of way.
Sorry, thank you.
Yes, let me see if I can get, we've went out of focus. Let me turn it on and then back off. Sometimes it's just a simple change the camera. Oh, what do you know? It's not working. And I don't want it to be blurry for this part. Focusing, focusing, focusing. One more moment, everybody. Sorry about that. Well, we can use this one. Yeah, it's a little pixelated, but at least it's clear. Get this out of the way. All right, so the way,
Benefit of multiple cameras.
yes. So I like to just hug it in my side between my hip and oblique if I have a secondary hand tone. And then I'm going to press in, rotate, traction out, rotate, press in, rotate, traction out, rotate.
Smooth it out. Make it like a butter. There we go. Ah.
Yeah, so after a few repetitions, you can curve it out. And then go the other way, press in, opposite rotation, traction out. Press in, opposite rotation, traction out. Good. I'm glad you had me use more of my whole body instead of just my upper body.
Yeah.
And it feels better to her too.
Definitely.
Okay. And then the last one we're going to do is for the hip. We're going to do that same sequence, but for the hip, right? So what we'll do is, and if they were draped, you could undrape the leg, or you could do it under the sheet. And so for the sake of ease, I let them know I'm going to move your leg. I'm going to bend their leg. I'm going to place my foot on the table so that I can have the knee directly over the hip. I'm going to support around the leg. This is for a lot of hip stuff. And I'm going to simply compress the thigh bone, the
Femur?
head of the femur into the acetabulum for about 30 seconds. Remember, we compressed the arm bone into the shoulder socket.
Just use your forearm too.
You can. You could use your forearm. Just make sure it feels comfortable. I'm right over the patellar ligament. So I'm inferior to patella and right over the kind of tibial tuberosity, or a little higher. And that's what I'm using to compress down into the joint.
And what's nice if you have like one of those electric tables.
You drop the hydraulic all the
All the
way
way
down
down.
so you can get more of your leverage over them. If you have a super tall client and you're super short, this won't work unless you're able to bring it really low. And then I can hook under.
I can actually feel you like sinking.
Yeah, okay, good. And you can also hook under, support the leg. We have a few different variations. The easiest one, I think, is take your outside hand underneath, interlace your fingers, so the inside hand interlaces, and I'm going to also use my leg, and I'm going to lift. And so it's not a huge lift. I'm just move a couple inches, and I'm tractioning the leg, the femur, superiorly out from the hip socket. And again, about 30 seconds or so. Always check in, make sure it feels safe for the knee. We're not doing a whole lot of crazy motions for the knee. It's primarily in a safe position, but it's important if they are healing, always be sensitive around those areas. And then I'm going to keep the same interlace kind of relationship. And I want to find a way to support the legs. So everybody has a slightly different way of doing this. So find what works for you. And again, I want to have the idea of pressing in, rotate, traction out, opposite rotation. So I'm pressing in and internally rotating, and then I'm tractioning away and externally rotating for the first portion of this strain, counter strain, or mortar and pestle. Compress, rotate, decompress, compress, rotate, decompress, opposite rotate. Strain, rotate, counter strain, opposite rotate, strain, counter strain, opposite rotate. And then compress, external rotation, decompress, internal rotation, compress, external, decompress, internal. So imagine like you're just lubricating inside that joint capsule. You're breaking up any static, any fascial patching or casting, like a cast goes around an injured bone. The fascia will cast in the same hard, immobile way to support or brace an area of vulnerability. You want to break through that fascial cast or patching.
Hey Heath,
Does this,
I'm sorry. Can
Go
you
ahead.
turn the camera angle a little bit so we can see how your body it's hard on the angle to see
Yes.
the counter pressure on her foot
Okay, cool. Let me get a sideways view.
and good positioning on that.
Yes, appreciate that. Yeah, and I'll do that for the second side so you can.
Thank you.
Yeah, no, I really appreciate that. Thanks. Let's see if the better camera is going to work or if it's being better or not. Let's see. No, it likes to be out of focus today. Huh. That's good. Close focus, not so good. All right. Thank you for entertaining me. So what we'll do, we let them know I'm going to move your leg. Is that all right?
It's all right.
Okay. Good. I'm going to use my lower leg to support. You know what? I think I got the same problem with the camera angle. I got to lower it a little. Upper. I got to raise it a little bit. So I'm supporting approximately Achilles here. I keep the knee over. And so figure out for your own foot where you're in a comfortable position. And first, yeah, you okay? Achilles, calf, this part doesn't matter, just so it feels safe and friendly. And I can take that forearm, whatever is going to be easy for you. I'm going to create that strain. I'm compressing femur into acetabulum, about 30 seconds.
would this also be good for the knee joint and the ankles and the likes?
A lot of times they're related. So if you release unnecessary tension in the hip, you're going to automatically help release low back and knee tension.
But it's indirect.
But I would say it's an indirect benefit to the knee and ankle. Whereas like the first thing we were doing was clearly going to help the hip and the knee directly.
That wasn't my question, but that actually answers another one I didn't have. So thank you. I was just curious if there's also those. Sorry?
Can we answer your first question?
I was just curious if you also had the pulling, twisting, pushing for the knee and the ankle as well, or elbows, wrists, or was it just for the hips?
No.
No,
Okay, thank you.
Yes, we do it on the toes,
Yeah.
fingers. You got
In and out of the ankle.
I do that, the calcaneus, yes. And then I like to.
Thank you.
Yes, great questions. I appreciate that. And then we're going to support. I like to take outside hand under and hold, and we have it braced. And then I'm going to lean myself back, and I just take the leg along for it. So don't think of trying to lift up a leg toward the ceiling. That's going to be way too much effort. But here, my biceps somewhat supportive, but really it's my bottom leg
And it feels like this arm.
and leaning back. Yeah, yeah, good. So get that decompression.
It's like you're levering the lever.
Yeah, this is going up, but this is sandwiching and keeping it stabilized. So I kind of have the shin, the crux in a nice vice grip. And then we do the compress and rotate. So you could use your hands, compress, rotate, decompress, rotate. I like to have one hand under for the lifting portion. It doesn't matter if you choose to do the inside or the outside. Compress, rotate, lift, opposite rotate. And now I hope the angle's a little better to see what is happening with the lower leg. And it's just going along for the ride. I'm not trying to create any rotation. I'm not doing anything in the knee at all other than compressing the femur straight down. The rotation is happening in the hip socket. So make that clear that you might see the lower leg move a little, compress, rotate, decompress, rotate. But all the action, the pressure is in the hip socket, rotation out of the hip socket, rotation. And this is kind of an afterthought. But do be mindful if they are healing in the knee that you may need to be a little more sensitive. Yeah. Originally we were trained and like you hold the leg like this and it just requires a lot of upper body strength. And we like to support with the other leg. But if that's not comfortable, you could try different modifications.
Yeah, and again, you can do it to the wrist, you can do the ankles. Yeah.
We'll even show you how to do a version of that in prone this afternoon because we move through time really, really
Okay,
fast.
so we got your client nice and bolstered. You got their head bolstered, neck and cervical supported, and then you got their front knee bent. This knee is supported. We got a nice bolster under there so that the knee is about the same height as the hip and the bottom leg is straight. Just make sure you have your dog there to keep it straight. All right, so our first technique, we're going to be addressing and working around the lower back and particularly around the ribs to support the diaphragm. And why are we choosing to work with the diaphragm? Well, the diaphragm has a lot to do with the low back. The diaphragm is a beautiful muscle that not only traces around the ribs, but it also drapes over the lumbar vertebrae. So every time that you take a beautiful, bellowing, deep breath, you are gently moving, flexing, extending as you exhale, flexing and extending and mobilizing those lumbar vertebrae. You're also working with and massaging indirectly your own very heart. That always makes me smile. So as we ground, as we center, let's together could take a collective inhale and exhale, breathing into the health of our spine, breathing into the flexibility of your spine, and smiling to your magical, magnificent, biological, breathing beingness. All right, let's celebrate what we can do by continuing to emphasize how things are going well. So we're going to go and see how well my partner Heath is breathing into his low back. And I'm just going to undrape by undraping his shirt. So I'm going to take your shirt up. Thank you very much, sir. And I want to find his ribs. I'm going to use just a wee bit of lotion. I think Heath mentioned before that we use like a dual purpose. And take this swatch off so that we can still glide, but also have a little bit of grip on the tissue. So what I'm going to do is I'm going to use kind of the inside portion of my knuckles to trace around the ribs. And my pressure is going to be, I'm going to emphasize most of my press in the anterior body, but I am going to continue to travel down both the posterior at the same time. So you can do this with fingers, but I have found that if you can lead, pardon me, Jake. Yep, watch out. There we go. Thanks. So if you can lead, let me see if I can get a little bit more of me in there so you can see a little bit more of the technique too. There we go. I think that works. Let me know if you need a new angle, different perspective, always open to your feedback. So I want to get the inside of my knuckles to travel down and across the lower ribs. So I'm just hooking in and dragging the tissue. You can start at the fingers, then you can make your way towards the knuckles. Once you hook in with the knuckles, that's when you can start to add a little deeper pressure. I want to get underneath the ribs, hook under the ribs, and then continue to follow, tracing the ribs all the way around and down. One hand going towards the spine, one hand going towards the belly, the solar plexus, thanks. All right, we're getting a little bit more blood here. So this time I want to integrate and work with the breath. So Heath, I'm going to have you take a nice deep breath in. On the exhale, I'm going to travel around and down. Ooh, how's that pressure?
Good.
Can I use more or less?
More, and it might not be clear, but it's this part of Nicole's knuckle at the base of the index right here. That's really where the bulk of the pressure or intensity
Yes.
comes from.
Gotta tuck your thumbs in. I know they want to work. So the hardest part is to keep the thumbs out of it. Hook underneath that lower rib. There it goes. That breath in helps a little bit. On the exhale, here we go. That's where the pressure is added. And I'm going around. Nice.
So you're following the bottom ribs in the front and back body, just inferior. You can feel the ribs, but you're also attempting to
Decompress. I'm
Yeah.
creating some more space. So if I want to decompress and create some more space, I can add that arm up into it. So I'm just back it up a little bit. I'm going to drape that arm over the head like that, and then continue. So Heath, again, take a deep breath in. Exhaling. My pinkies like to flare out a little. How's that feel? Do one more of those.
Yeah, and check in with your partner if you're practicing it. It should feel a little edgy. You might need to press more into the mound of the index finger, the root of the index finger, and really trace that fascia, release that diaphragm.
And it's a different way of working with your hands. So it feels really good. It's a lot less effort. I think you'll enjoy it. So we can also add a little tail tuck on the tailbone on the exhale. So here we go again, Heath. Deep breath in. I hook in with my fingertips. I can find my locate where I want to be. On the exhale, add a tail tuck. Tuck your tailbone as we trace under. Oh yeah, that's a good one. Now I'm able to actually get all the way around, feel myself wrap around the body a little bit more. Let's try that one more time. Yeah. Nice. Feel good? Any feedback for me on that?
Feels good.
All right, cool. So from here, Heath can bring out his arm. Now I just want to soft fist the erectors. I'm just going to go down the erectors a little bit with a soft fist or up, you choose. So we just want to create some space here. Creating some space. At the same time, softening this tissue, opening up. I'm mostly focusing on the part of the spine that's closest to the ceiling. And then my opposite arm is going to come in and traction that hip forward. I'm going to create some more space. So I want to traction that hip bone forward and then bring that soft fist up or down the erectors, you choose. I like to go up. I'll do a few of those. Remembering that when you're using your soft fist, you're stacking by your knuckles, wrist, elbow. Should be really, really effortless. There should be no curves in your wrist as you're moving. So you're not pushing with your wrist. You're actually using your whole body, using your arm like a lever to create the technique. Save your wrists, right? So you don't go home with osteoarthritis after your sessions. You can knuckle and fingertip along you can bring your finger pads and move through the lamina groove if you like, creating some space there. Working with my knuckles. Comfortably deep, Heath. 2, 3 passes. making the space. That's what we're doing here. So next time that I soft fist or work with the knuckles on the spine, I'm going to ask my client to hug, do a little call for motion. I'm going to have them hug their knee into their chest, and that's going to create even more space in this low back area. So my partner's going to take a deep breath in. On the exhale, I'm going to have you bring and hug your knee up towards your chest. Nice. Okay, cool. And go both ways. So we'll try one more time going up. There we go. Beautiful. And then we can also, let's go down on the back. I'm just going to adjust the camera a little bit so I don't step on it.
And I'm not sure if Nicole said, but your client can help their knee lift by using their own hand and arm.
Didn't say that, but yes, you can. Here we go. Deep breath in and out. You can use a forearm here. You can use just an open palm if that feels better, or those knuckles down the spine. So I like the soft fist right now. Deep breath in and hug that knee in towards the chest. Take it all the way down. Maybe you can even get lucky and take it through the SI. One more time. You got one more in you? You feel the space in your low back?
Yes, it's a good low back decompression. And we're also turning off, if there's spasms here, that reciprocal inhibition by activating the core, turning it on, and decommissioning, decompressing any low back spasm.
We can also add pelvic tilts here. So we can either, I can do it from both directions. Let me do that from here again. And this time, Heath, you're gonna do that cat-cow here in this position. So you're gonna tuck your tailbone. You're gonna, make your back nice and flat in my palm, and then arch your back, point your tailbone to the wall behind you. That's what I'm talking about, pelvic tilts. So now you're gonna do that with your breath. So you're gonna inhale one way, and then exhale the other way. So that's another way to kind of get the same effect. Inhale one way, exhale, tuck.
Yeah, it's a little easier for the client if they're able to create range of motion in their pelvis. It's a little more challenging for most clients to lift their knee toward their chest. Just keep that in mind. Not everybody can do all of these.
One more time. Beautiful. Nice. And again, you can always use a forearm down here. You can use an elbow. You can work specifically in the lamina groove. So here we go. Let's try that one more time with the lamina groove. And you're letting the
What is
spine.
this technique?
Go ahead. I couldn't hear you. Can you say it again?
What does this technique do for the spine?
Yes.
All the
It's for the spine and the hips. So this is to help with joint degeneration, creating the space. Remember that a lot of the issues of the spine having to do with less space. The articular space gets compressed, more and more compressed, the articular space, the cartilage, as over time, right, as one of the options, or through a dehydration, gravity, impact, and nutritional deficiencies can narrow the space between each of the bodies of the vertebrae, leaving and dehydrating that articular disc. As that disc dehydrates, we create more inflammation in the body. So much inflammation that sometimes bone spurs will grow, and that we totally dehydrate or degenerate that articular disc, that bones begin to grow together from spine to spine, creating like a spinal fusion. So this is in itself is a form of joint degeneration, spondylosis, that can lead to spinal surgeries like a laminectomy, because maybe there's a pressure on a nerve because the narrowing of the space, maybe there's stenosis, or et cetera, et cetera. So all of those conditions that we talked about in the spine, we want to create the opposite, right? Everything was talking about the compression of space, the narrowing of space. Here's an opportunity to create more space. Hopefully that answers your question. Cool. I'm guessing so. Let's see. Go ahead.
Thank you. I was just saying I had thumbs up. I don't
Oh,
know.
okay, I couldn't see. Sorry, it's really hard. We have multiple cameras going on at the same time, so it's so much easier if when you talk to me. So thank you for taking yourself off of mute. All right, cool. So yeah, this is all about space making in the body. The next one that we have are, let's see. Oh, we can do those same pelvic tilts, but with, this is really good for the hips. I'm gonna bring the camera a little closer so that you can see. And maybe if you've been with us before, this is one of our favorite techniques, but I'm gonna find a place, maybe TFL, boom. Maybe glute medius, oh my, or piriformis, right? Oh, I got a little response there.
Little
So,
jolt.
Little jolt. So I found that piriformis. I'm gonna rest my press there. And now my partner, I'm sorry, is that comfortably deep? Too much still?
Too much.
Too much still. Now?
Yes.
There. Okay. Found his perfect pressure. I can just rest my press there. And now I can add those pelvic tilts. So again, Heath, inhale, arch the spine. And exhale, flatten and fill my palm up with your low back. And this is great, again, for low back mobility, SI joint mobility. This is great for mobility in the hips, acetabulum. It's also creating some more flexibility, less pressure.
So if your
Oh,
client
thank you.
can't move, it might be you're doing too much pressure.
So you can rest your press anywhere in the glutes. So we can also find another spot to rest our press. Is that a good one?
Yeah.
More or less?
It's good.
Perfect. Okay, now Heath can do a nice big deep breath in. On the exhale, lift your knee towards your chest or hug your knee toward your chest as you hold pressure, steady press here.
I see it. It's way easier now than 5-10 minutes ago.
Oh, really? Oh,
Yeah.
cool. Excellent. So I find new spot. Ooh, rest my press. Exhale, hug that knee in towards your chest. And then one more time. I'll go TFL.
Oh, TFL.
I know, right? Oh, yeah. And then we'll roll it out and give it some sugar, sugar, sugar. Nice. Good deal. Any questions? Any other questions so far? All right. Pin and stretch the psoas. So now I'm going to have you just bring your shirt down.
Mhm.
I'm going to have you roll on over and face
Sure.
the camera.
Those from this side.
Oh. Good there?
Yep.
All right. So pin and stretch psoas.
So just as a reminder, the cushion under the head is to help keep the cervical vertebrae happy and aligned with the rest of the spine. And then this bolster helps keep the knee in a neutral position.
Ooh.
Sorry. Helps the knee be in a neutral position. So if this bolster wasn't here,
Sorry, here we go.
it would be straining these ligaments and tendons on the SI or the deep six. So by placing the prop here, getting the knee approximately at the same height and level as the greater trochanter, that helps these structures in the back of the hip and IT band release a little.
Okay, we're on number 8, just so that you know.
Okay.
So I'm going to find Heath psoas. So I want to pin and stretch the psoas here. So this is a really great position to access the psoas because all the tissue, especially for more of your overweight clients or clients who are just larger in size, this is a little bit easier to access and press the psoas. You don't have to, you automatically bypass the intestines. So to find it, I find my partner's ASIS right there. And then I find my partner's navel. They can either point it out to you or you can find it yourself. Oops. And then you can go about halfway, you can meet your fingers and start to gently press in and deep towards the spine to find the psoas.
And Nicole's kind of circling in. And you got to move through rectus femoris, rectus abdominis, and the TVA, the obliques.
There we go.
Yeah, and it feels kind of rope-like, kind of cable-like, a little edgy, a little achy.
If you want to be sure that you're on it, you can press it and then have your partner just gently bring their knee towards their chest. Oh, the muscle flex underneath your pressure.
So that's confirming as the psoas is the primary hip flexor, lifting the knee up and feeling it engage under your hands confirms that you're on psoas.
All right, is that comfortably deep for you?
Yeah, I guess
All
so.
right, so first I can hold steady press here. Just a nice, comfortable deep, opening up into the psoas. You can also add a pin and stretch. So I'm going to reach for the ankle, bend the heel towards the glute, partner takes a breath in. On the exhale, I maintain steady pressure here on the belly, on the psoas, and I gently just open the leg back up, in and stretch. I release, inhale. On the exhale, bring it back. Inhale. And exhale.
And on any pin and stretch techniques, you don't have to do the pin and the stretch. Nicole started just with the pin, a compression on psoas. Then she added the psoas compression and the stretch of the psoas muscle. But you could just get rid of the pin and just do the stretch, just get that part. So if they can't handle both the pin and stretch, maybe split it up and then check in and see if they're able to go further.
Yeah, so we can just add the stretch. You can either just walk it back. You can stabilize at the hip. Keep the heel towards the glute as you bring and gently stretch into that psoas. Getting a nice decent stretch there, Heath?
Yeah, psoas and iliacus and rectus femoris. It's good for low back, but this could also be something really important for hip and knee health.
Yes. You can also just drop that leg down so that the leg hangs off the table. If that's a heavy leg and you don't want to lift it, you can just drop it down off the table here. They can add their own little stretch, bring their arm over the head, and then here you go. You got a nice side body psoas stretch. Does that work?
Mm-hmm.
All right. Bringing that leg back up. So different options to opening and working with the psoas. Yum. All right, let's.
Another question.
Oh, I think there's a question. Cool, come on in.
I'm not sure if it's a question, but I know like when you're doing that psoas, when you're digging into the psoas and then you do that stretch, because you have to go like maneuver around like the rectus femoris and the abdominal muscles. Like if they have a heartbeat in their stomach, would you still work on the psoas that way?
Yeah, so everyone's gonna you have that big artery there.
Aorta.
The aorta, giant artery. So likely you're gonna feel the heartbeat no matter what, right? But you just wanna make sure that the heartbeat is not directly under your pressure. So it can be next to your pressure, can be behind your pressure, but just not directly under your pressure. And if you can't tell the difference, then go a little higher or go a little lower because the psoas
or a little more lateral.
Little more lateral, yeah. So because the psoas is a really thick muscle and it extends all the way from the inside of the femur to the lumbar vertebrae all the way up to L5, right?
L1.
L1,
and
sorry.
the rib cage, yeah.
Thank you. Yes, going all
Well,
the
I
way.
was just wondering that if you have like if you can feel the heartbeat in the stomach, like in the center of the stomach, not to work, like even on the psoas, because you could like I don't know, like put the client in the hospital for what is it called, like the AAA or double A? I'm not sure what it was called. It was like
If they were
If-
deep vein thrombosis, like if they were in jeopardy of throwing a blood clot, aneurysm, stroke, heart attack risk, something like that, this would be contraindicated getting this close to the arteries, yes. However, if they have a clean bill of health, they're in good cardiovascular health, there's no extenuating circumstances, you can be a little more liberal with how you work near blood vessels. But again, Nicole's trying to talk or specify that you might feel a heartbeat adjacent, and that's okay. You can often feel the aorta through the adjacent tissue, but you want to feel it like maybe on your fingernails or your finger pads, not directly under your fingertips. You just don't want to be pressing directly on the heartbeat. And if you are feeling that, you want to move generally with psoas more lateral. Does that help?
Yeah.
Okay.
You don't sound certain.
But the two main contraindications for working your blood vessels are any cardiovascular extreme projects. So if they're on Lipitor or some statin for their cholesterol, that's not an
No big
extreme
deal.
cardiovascular. If they're taking blood pressure medication because they just passed out, if they're taking blood pressure medication to control their blood pressure and it's under control, then yeah, you can work in this area. But the other example I rushed ahead to, if they just pass out because of
Yesterday,
their blood pressure, then no, their heart isn't going good. If they are that blood clot, that DVT risk, then no, you're going to leave it out. And if, of course, if they're pregnant, you're not going to mess with any blood vessels, much less direct pressure on the baby or the uterus.
and that's primarily from our direct experience, from not only from our teachers, but our own hands-on work from what we've been practicing for the last few years, 20 years. So hopefully that shines some light and gives you some permission to work with clients who have a pulse in their belly.
You just want to make sure your pressure isn't directly on the pulse, and that might take some fine tuning to learn that it's more indirect, it's adjacent. So
Right.
really ask yourself, am I right on the heartbeat? So if you had someone who was safe and happy heart, you could just put your hand right over the navel point with a little pressure while they're laying on their back, and you'll feel thud, thud,
Yes.
thud. And that's direct. If you just move a little to the side, you might feel thud, 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 but it feels like
Should be
it's,
faint.
yeah, it's more like an echo from the accompanying or adjacent muscles.
Mhm. Is that helpful to you?
Yeah, I just heard differently. That's why I'm asking now. I heard not to work on the stomach area if you feel a heartbeat, like a direct heartbeat in the stomach, because it could lead to something more serious, and to just refer the client to a hospital or to their doctor to get checked out.
Yeah, I
Well,
know
Not really.
in the beginning, in a lot of beginning massage,
Yeah, and I was going to say it. The more you study, the more modalities contradict themselves.
yes, keep studying. I mean, when we learned don't put, endangerment zones, don't put pressure,
Femoral triangle.
don't put pressure right on aorta, don't put pressure on the
radial
anterior neck. But the more you learn, the more you understand your anatomy, and you can visualize where things are located musculoskeletally and organally and blood vessel and the nerves. You can get a little more safety. If you're not feeling safe,
Then
please don't do it.
No, because that's conveyed through your touch.
Yeah, if you're feeling
Your
unsteady,
fear, your worry, your
Yeah.
doubt is conveyed through your touch. So if it feels like something that you wouldn't do, then don't do it. We're not here to force you to do any techniques, but we are here to open you up to the possibility of, and you find out what works for you and throw away the rest. We don't take it personally.
Okay.
All right, so moving on to hamstrings.
Mhm.
Let's get a little hamstring in here, a little mobilization. So first I'm gonna bring the hamstring just a little deeper. I'm gonna lift this up a little higher. Thank you. And I wanna get a little more lotion because he has hair here and I want to be kind.
Thank you.
All right, so now I'm gonna bring my partner's foot. Let me adjust the camera so you can see what I'm doing. There we go. I'm gonna bring my partner's foot to my outer hip. So this will give me some ability to move, create some range of motion in my partner's hip using my own body weight, right? So I'm not pushing or forcing. I'm actually using the strongest part of my body, my core, my center, to help move my partner through range of motion. At the same time, I'm gonna add some soft fist, some pressure on the lower leg. So first, I'm going to add the pressure just so he knows and experiences where I'm going, get a sense of what's happening. So from here, I can add a nice double soft fist down the hamstrings.
And this is appropriate for knee, hip, or low back projects, keeping in mind that the hamstrings are notoriously tight from extended periods of sitting. A lot of times they form in a heightened short. They're notoriously weak and short and dysfunctional. So this will get more blood, get more activation. And as we start to maybe create
Add some
motion,
range of motion. So I'm going to follow pressing the knee up towards the chest at the same time. I'm following the hamstrings up towards the head. So this is also creating some nice, again, space in the lower back, freedom in the hips, mobility for those hips. And that's what we're looking for. More freedom, more mobility in our bodies so that we can do the things we most want to do. We can get up and off the floor easily. We can get down on the floor easily. You can lift your kids up easily. You can play whatever sports more easily as you move through and find more space in the body. So I just want to make sure I don't miss anything. Run your knee to chest. And any questions on that one? That's a nice, pretty simple, straightforward. I just want to move a little faster. And then let's get to the adductor. So I'm coming back behind the table so that I can work the adductor here. And I'm working on top of the straight, the adductor of the straight leg. I'm just going to adjust the camera so you can see me a little better. There we go.
I think you can raise that camera up if you need.
So slimy.
I don't know if you want me.
Which one would I do that with? This one?
No, the one in front.
This one.
Just, yeah, you can go up.
All right, that'll work. Thank you for your coaching. Thank you guys for your patience.
Just for a second, you need to push it down. You got it. Yeah.
All right, cool. There we go. So you can drop your arm back. So
Yeah.
it's getting tired. So now I'm just going to work on Heath's adductors. So this is adductors. They're related to knee pain, hip pain, low back pain and tension. So if you're not already working adductors in some way in your sessions with your clients who have knee, hip, or low back pain, start to think about how you can integrate that now.
This will also be an endangerment area regarding the blood flow.
Yes.
So the same exact contraindications that we mentioned for psoas near the aorta is that nothing with a risky cardiovascular project and no pregnancy. You're not going to work anywhere that could interfere with the blood supply.
Mhm. So if your client was a DVT risk, we would leave this out. If your client had cardiac issues, had a stroke recently, we would leave this out. But if they're healthy, they're recovering from surgery, they're looking for some new space and new ways to feel in their body, we're going to work and compress the adductors. So a couple ways that you can compress the adductors. You can do a nice big compression with your palms. So you can lean in and press. I'm going to gently compress and hold over the adductors for a good 3 breaths, 30 seconds or so. And I'm going to trace this inner adductor line all the way down towards the knee and then back up again. But I'll show you different ways that we can compress. So taking your time, letting the body adjust to the invitation to be soft, right? So sometimes we're just so used to being tight, we're so used to being short, we're so used to holding on that it takes a little bit for our bodies to remember how to let go. And that's also in part what clients come in to do. They remember how to let go, how to de-stress, how to feel comfortable in their body. And then I'll release. So another approach is my forearm. So I'm just going to use me as part of my forearm to compress over the adductors, shoulder, elbow, nice alignment. Got my head nice and long, my own cervicals I'm protecting. My low back nice and long. And again, 30 seconds, 3 breaths here. And then another option is to work with a knee, the front of your knee. And so I'm just going to bring the leg a little further back so it's closer to my body. I'm going to bring the tibial tuberosity, the front of my knee, right on the inner thigh. Press and rest. Really simple, not a lot of effort on your part. And hold. Does that feel comfortably deep?
Mm-hmm.
I'm going to go down and then I'm going to travel up. Again, if you feel the pulse here, no problem. As long as they're not a risk, a cardiac risk, or pregnant. But relaxing those big, massive adductors that play a big role in the movement, stability of your hips. And I know that a lot of my clients who have inner knee pain massage and work the adductors and knee pain disappears. And train them to do adductor stretches regularly.
Stretch and strengthen.
Nice. All right. So there's our adductors. And then we can come up to the shoulders. I'm going to adjust the camera Another time here. Getting a new part of the body. Looks pretty good. What do you think, Heath?
Great.
There we go. All right, so shoulder work. So we find that working the hips and the shoulders inside lying is really optimal, mostly because you have all the opportunities to create range of motion, to get 3D with the body. So here in the shoulder, I can hook underneath that, get elbow help, hook elbow to elbow, support the front and the back of the shoulder, and add some gentle, nice shoulder rotations, right? Really simple, but really yummy. Feels good. Invite that range of motion.
One of the common mistakes when people first practice this is that you might rub or rest your forearm on the ribs, and that does not feel good.
And then I can add a little pressure, a little work on the side of the neck. So anywhere along the lateral neck, I can press with my thumb, I can press with my fingers, I can press with my knuckle. I can pin down the lateral neck, and then stretch back. I bend my front knee, I'm in a lunging stance, pin down that tissue, I press into my front knee, straighten my leg, and lean back to get that stretch, that traction. So I'm gonna travel down the lateral neck, pin and stretch. Yum.
Mhm.
And then I'll travel back up. And then stretch.
So be methodical, intentional. What are the structures you're working with? Where are you aiming? So is it more splenius capitis, cervices, working that first head of the trap? Maybe we want to focus on scalenes. So being intentional, continue to build out your intuitive sensing by practicing visualizing your anatomy images. So you almost have X-ray vision. You can connect what you're feeling with what you're touching under the skin.
We can also do from C7, I'm gonna hook my fingers from C7 on the top of the trap, C7 all the way out towards the acromion. So I'm gonna hook in, press, and then straighten my front leg, lean back. Press in, lean back.
On the top of the spine of the scap, second, third head of the trap, or even really close to supraspinatus.
Yeah, right on supraspinatus here, so a little rotator cuff work.
Really good for any kind of AC injuries or tension, any kind of shoulder bursitis, tendonitis. It can be edgy. Trying to create a little more mobility and collaboration between clavicle in the front and the spine of the scap in the back.
Then we can add a little opening into the pecs, into the chest a little bit here. This is all to help and support the cervical spine. So I'm going to come to the outer edge of the pec muscle. I'm going to place my palm and traction that pec muscle in towards the sternum. If you have bigger breasted tissue, you come more towards the shoulder joint. Traction, hold, partner takes the breath in. On the exhale, we open the arm gently for light.
So this is more of like a superficial myofascial support. You're not pushing the muscle over the bone, but rather you're allowing the skin and the muscle to slide in opposite directions.
Yeah, so it's a nice pin and stretch, but the pin is not pressing down into the body, but the pin is pressing across the body towards the sternum.
Like you're trying to flesh the superficial fascia of the pecs toward the sternum, while the deeper layers of fascia are moving in the opposite direction.
Nice. Also great for the shoulders. So we can add a little bit more shoulder work here. So let's get to that lateral border of the scap. I'm just gonna pin down the lateral border of the scap, hold it with my palm, pin it down. Partner takes the breath in. On the exhale, I'm gonna drop the elbow towards the floor and just hold that scapula down. Hold it light. You can hold it down. Sometimes it's a very powerful scapula, and you can hold it down with a forearm, and press the elbow towards the floor. Medium and then deep pressure. Oh, that's a good one.
So it's as though Nicole is stabilizing my scap toward the spine, so the scap doesn't slide up as we're stretching the arm and clavicle up.
Holding it there and pressing it down. Then we can add multi-angled stretch here. We can get a nice little lat stretch over the ear, over behind the head, open the arm. So kind of play with your partner's angles and see where the freedom is in their shoulder. And then there we go, that's it. So we can now go to the, I wanted to make sure that we had time for the prone work. So I want to throw this thing on a face cradle thing.
Okay,
here.
so we'll, instead of doing everything on both sides, we're gonna just focus on giving you guys as many options and opportunities to help support your clients. So
Unless
keeping-
you have questions, unless you have more comments, questions, we really appreciate your feedback and learning where you are so
And-
we can support you.
yeah, what you most want to learn or are interested in and curious about.
Is that comfortable? Let's check it out. All right, so the one technique that we wanted to do, make sure that you saw for prone, is on the shoulder, working the shoulder. I'm trying to decide which is the best angle. So figuring that out. Give me just a moment. I'm going to adjust the camera here again. I got stuck in some wires. Down. All right, I think that'll work. So this is another approach to working with osteoarthritis in the shoulder. This is kind of orthopedic massage, working the side of the joint.
Yeah, any kind of shoulder injury, bursitis, tendinitis.
So what I'm going to do first is I'm going to rotate that shoulder down towards the table and gently traction the arm towards the foot. So I just kind of rotated it down, bring it all the way down the arm, and then traction that arm out. I hold and maintain that traction as I bring the arm off the table. And I continue to traction. Once I got that traction going, after I do a little bit of traction, then I'm going to come underneath the arm. I'm going to find that pec attachment, have my partner breathe in,
Pec minor.
pec minor, thank you, pec minor attachment. And on the exhale, I'm going to lift up and stretch up. And release. I'll do it 2 or 3 times. So I'm going to find that pec minor attachment. So find that coracoid process, that bony landmark. There it is. I'm going to press gently there. Partner takes a breath in. On the exhale, I lift gently and then also traction the arm out and down. I'll do that again. Lift and traction down. And then I'm going to work that posterior delt a little bit. So I can use a little bit of petrissage. Ooh. Little deep compression, working the posterior delt, should feel really yummy. Activate that a little bit. And then I want to mobilize this joint a little bit. So I want to hook in on the top and bottom of the joint. So I got my fingers, I found my partner's acromion process, there it is. And then I'm going to hook in right at that acromion process there. And then my bottom hand is just hooking in underneath or near that lower upper arm. And I'm going to rotate the shoulder up, rotate down. There we go. Here we go. Up and down. How's that feel?
Good.
I'm tractioning the whole time, pulling the arm out of the joint, and at the same time, mobilizing, moving that shoulder around.
It's like you're swishing the head of the humerus around the labrum, the little cartilaginous flap in the glenoid cavity of the scap.
And then bring it out and down. And that's like a nice little series for that shoulder.
Yeah, really relieve the shoulder quick and easy.
Well, any questions on that? Anybody need to see that one? Great. And then there was, was there another one?
We're doing the back hip stuff. Do you want me to talk through?
Yeah, because I don't really
Yeah.
remember it, if you don't mind.
Oh, I'd be happy to. This is a good one. Love this one.
Okay, cool.
Let's switch
spots?
roles.
You're all right
Yes.
to do that? Okay.
Yeah.
Might take me a moment or two to get my brain turned back on.
This table is very warm.
Very warm. Yes. All right. So this one we learned from 2 of our favorite teachers, Eric Dalton as well as Benny Vaughn. And Benny Vaughn, for those of you who don't know, is from everything we've learned, he's like the father of American sports massage, and he's still an incredible inspiration. But What we're gonna do is from the opposite side of the table, we're gonna find that ASIS. We're going to begin to mobilize it. What's happening on this side of the table is my legs are bent into the table. I'm gonna support the ASIS and wrap all the way around. This won't be appropriate for everybody. You know the clients that you have rapport and safety with. I feel the SIS, but what's really important is that I don't curve and dig my fingers into iliacus. That would suck. So have a nice kind of support on ASIS. So I'm going to start with my top palm on ASIS, and I'm just going to simply drop my seat back and stand up. So I'm not rounding my spine. Really important, everybody, protect your back by keeping your head over your heart, over your hips. My thighs, my quads are pushing into the table, and I just bend my knees, drop my seat to help lift up Nicole's hip. And then I'm going to begin with my other hand. We can press onto the biceps femoris, in the back of the hammies, that lateral group, with your palms. This could be for a hip, low back, or pelvis. You could use palms. You might want to use soft fists. Now, again, make sure you're not digging into iliacus in the front of the ASIS. Alternating is going to be a little more amenable for people's intensity levels. But if you want, you can also bring it into the hips, into the piriformis. But if you want, you could do simultaneous stretch and press. And so just notice if you do have a client, checking in with them, do you like the alternating better or the simultaneous? Nicole, are you asleep?
Oh, I like the alternate.
Okay, you like the alternating.
I thought you were asking
Yeah.
them to ask the
Yeah,
client.
you can
Sorry.
do that too. Another version is the lift the hip and then find the PSIS on this side, right? PSIS is kind of the bottom of the lumbar, the top of the sacrum really is the PSIS, and it's the top of the SI joint. So still with that top palm, lift the hips. Now my opposite hand, opposite hip, this hand is going to find the PSIS on my same side. I'm not on the opposite side, I'm on the same side. So you can even give it a little nice general compression, and that's really good to help mobilize the SI. So alternate, stretch, compress. And you can find a couple different spots. You can move along the whole length of the SI as you do this. Some people that does not feel good in your wrists, you could try a soft fist. Just be safe, be careful, make sure again you have a straight back. You're bending into your knees, dropping your seat, not rounding your spine. For more intensity, you do simultaneous. Again, be sure you're not digging inside. Is that too much?
No, I just.
Make sure you're not digging medial to that ASIS.
I like your palm better if that's okay.
Yeah, you could do palm pressure. Yeah, and do you want to feel simultaneous?
I like the alternate.
Yeah, Nicole likes the alternating. So try both, see what feels better to them. Is this one okay here?
Yep.
Good. So this is my soft fist. With practice, the soft fist can help replace the palm so you don't have to always use your hand or your wrist. And then we're going to switch hands. I'm going to bring my lower palm to support ASIS. Same kind of thing, mobilize and compress. A lot of times let's do the erector spinae on the opposite side of you, across from you. So opposite hip, opposite erector, and I compress and I stretch. A lot of times we think of the pelvis, and especially the two ilium connected at the pubic symphysis, at that cartilaginous joint, as one fixed unit. Here, I want you to visualize and imagine actually having two separate hip bones and feeling them, or encouraging, visualizing them moving in different directions, independent of each other. So I'm really focusing on Nicole's left ilium, and now I'm doing more of a simultaneous press on that erector spinae opposite of me as I lift the hip. Do you like the alternating or simultaneously better here?
Still alternate.
Still likes the alternating, and that's a little more calming. Alternate, rock, and compress. One of my favorites is to do PNF for the iliacus, or the hip flexor. So what we're going to do is we're going to support the hip. We're going to lift the hip off the table and just find the end feel. So at the end of the range of motion, right before the stretch happens. That's the the end feel. I could go further, but I just want to feel that spot right before it stretches. And now I'm going to ask Nicole, you're going to dip your pelvis, your hip down toward the ground in just a moment. So I'm going to find that end feel. Now press your hip down to the table into my fingers just with about 20% effort. She's going to continue to do that for about 5 seconds. Now let that go. Breathe in, breathe out. And then we have about a 10-second window to maybe lift up and find stretch. Again, my knees are bent, but my back is straight. Good job. So you have about a 10-second window where we can circumvent the stretch reflex and get a little further. And now the end feel has changed. So now at the second rep, and I have you press again, 20% effort. And so she's using the agonist, iliacus for the most part, some of those deep pelvic floor muscles, let that go. Breathe in, breathe out. This is going to be very beneficial for hips, pelvis, and low back health. And after the 20% effort, then you let them breathe in and out, and you can hold for a good 10 seconds as you encourage this neurological re-education of longer fascia. Let's do one more. You okay?
Yeah.
Lifting, spine, end feel, not as dramatic change between 1 and 2, but still quite a good significant improvement. Press your fingers toward the table. I'm being sure I'm not digging my fingers into the front of the pelvis. And then let that go. Breathe in, breathe out. I like to drop it. Let them know no effort, no muscling as I lift up and over. And this should feel pretty good. It sometimes even feels a nice adjacent opening in the psoas. And you might want to do just create a little diamond hand, fingers on the opposite QL, thumbs on the same side QL, and just do a little shake from your finger pads to your thumbs up and down quadratus lumborum from L5 to S1 and back. Just kind of shake that off, let that go.